Systemic lupus erythematosus, SLE, is a complex autoimmune disease characterized by multi-organ involvement and immunological abnormalities. The organ systems most commonly affected include the joints, renal system, hematological system, pulmonary system, central nervous system, and cardiovascular system. Lupus has non-specific skin diseases including photosensitivity rash, non-scarring alopecia, bullous lupus erythematosus, neutrophilic dermatosis, vasculitis, and vasculopathy. Specific cutaneous manifestations of SLE are subclassified into chronic, subacute, and acute cutaneous lupus erythematosus, CLE. The female-to-male ratio for SLE is 7:15. Men with lupus tend to have higher frequencies of renal disease, skin manifestations, and more. Diagnostic criteria for SLE can be remembered by the mnemonic SOAP Brain MD. The criteria include serositis, oral ulcers, arthritis, photosensitivity, blood disorders, renal involvement, anti-nuclear antibodies, immunologic phenomena, neurologic disorder, malar rash, and discoid rash. SLE is diagnosed if the patient has 4 criteria, including 1 clinical and 1 immunological criterion, or biopsy-proven lupus nephritis. Patients often undergo skin biopsy. The basic feature of all cutaneous lesions involves a perivascular mononuclear cell infiltrate. Direct immunofluorescence is positive in sun-protected healthy skin in SLE. The Cutaneous Lupus Erythematosus Disease Area and Severity Index classifies the severity of CLE with activity and damage scores. Total activity score includes redness, scale, mucous membrane involvement, and recent hair loss. Total damage score includes dyspigmentation, scarring, and persistence over 12 months, doubles the dyspigmentation score. Key immunological pathways identified in systemic lupus erythematosus SLE involve both innate and adaptive immune responses. The innate immune response includes TLR-IFN signaling, NF-κB signaling, immune complex clearance, complement, phagocytosis, and DNA degradation. The adaptive immune response includes antigen presentation, T-cell signaling, B-cell signaling, cytokine production, and mixed epigenetic modifications like DNA methylation. Multiple autoantibodies, often in high titer, are typically present in SLE, significant for diagnosis. About 70% of subacute CLE patients test positive for extractable nuclear antibodies anti-Rho and anti-LA, linked to other conditions. Low serum complement levels in SLE correlate with urticarial vasculitis and renal involvement, while antiphospholipid antibodies link to thrombotic issues. Routine tests for SLE patients include renal, liver, thyroid functions, inflammation markers like CRP and immunoglobulins. Photoprovocation tests help confirm if skin eruptions are triggered by UV or visible radiation exposure. Other relevant tests vary by affected organ and may include urine tests, imaging scans, and echocardiography. The lupus band test, LBT, is a skin biopsy that uses direct immunofluorescence to detect a band of immunoglobulins and complement components. It helps diagnose lupus erythematosus and predict disease progression for diagnosed patients. The LBT is positive in 70 to 80% of skin samples from systemic LE patients exposed to the sun. In cutaneous LE, the LBT is usually positive on lesional skin, while normal skin shows different deposition patterns. Systemic lupus erythematosus, SLE, is treated with a variety of medications targeting different aspects of the disease. Sun avoidance is essential for managing lupus symptoms. Non-steroidal anti-inflammatory drugs like aspirin and ibuprofen relieve pain and muscle aches. Anti-malaria drugs like hydroxychloroquine help with skin rashes and joint pain. Corticosteroids such as prednisone are effective for serious lupus complications. Immunosuppressants like methotrexate and cyclophosphamide suppress the immune system. Biologics like belimumab target specific parts of the immune system. B lymphocyte stimulator protein inhibitors control lupus by reducing B-cell activation. Inhibitors to type 1 interferon receptor improve lupus symptoms. Fish oil supplements may help manage flares. Acupuncture might also be beneficial for SLE patients. Anifrolumab is a monoclonal antibody approved for moderate to severe SLE. Rapamycin is safe and effective for refractory SLE patients. Fostamatinib may reverse T-cell signaling and improve kidney disease progression. Obexelimab targets B cells without depleting them.